Hi, my name is Connie Koklanis and you're watching the video Myasthenia Gravis Management. In this video, we'll discuss some of the common approaches to managing patients with Myasthenia Gravis, and we'll discuss again both surgical and non-surgical options for these patients. In relation to non-surgical management of patients with Myasthenia Gravis, generally this will involve oral medication, which will be aiming to improve the patient's symptoms. A neurologist will be involved who will be prescribing the systemic medication. Now, depending on the severity of the patient's myasthenia gravis, this will influence the decisions as to what will be prescribed. So, for example, a patient who has their breathing affected may be treated more aggressively than a patient who has milder symptoms. One of the first-line treatments in managing a patient with myasthenia gravis is the prescribing of anticholinesterases. And Mestinon is one of the most commonly prescribed drugs to patients diagnosed with this condition. As you've heard previously in some of the YouTube videos, some patients don't respond to anticholinesterases, in which case other options will need to be looked at by the neurologists. Another option is prescribing systemic steroids, such as prednisolone, and this will suppress the immune system and subsequently improve symptoms for the patients. And finally, pulse therapy can be provided to patients, generally those who have severe myasthenia gravis. Pulse therapy is where large doses of drugs are administered, and an example of this can be steroids, and they're given in an intermittent manner to enhance the therapeutic effect and to reduce the side effects. And this pulse therapy can happen, say for instance, on a cycle, like on a monthly cycle, etc. In terms of non-surgical management of ocular symptoms, so here we have the ptosis and diplopia where there's eye movement disorders. There are a few options. In relation to the ptosis, we can provide the patient with ptosis crutches on their glasses. Now, where a patient has diplopia, obviously removing the ptosis could be problematic in the sense that they will now obviously notice the diplopia. However, many patients also have bilateral ptosis, in which case it will be necessary to put some crutches on their glasses. Prisms are very difficult to prescribe in patients with myasthenia gravis because the disease is very variable, because the eye movement limitations are variable. It's very difficult to find a prism that would alleviate symptoms at all times. So generally prisms are not utilised in these patients unless you're at a point where there was stability to any eye movement disorder. So if the patient needs alleviation from diplopia and prisms aren't an option, then occlusion may be one of your only options there. And finally, Botox can be utilised in these patients. You could utilise it in patients where, again, there is stable ocular movements, so it's not variable, to bring back alignment, or you may want to use it as a preoperative measure to see what the potential for BSV or alignment is postoperatively. In terms of surgical intervention for patients with myasthenia gravis, a thymectomy can be considered. A thymectomy is a removal of a thymus. Where a thymectomy is being considered, a thoracic surgeon will also be involved and part of the team in managing the patient with myasthenia gravis. In relation to ocular surgery, we're looking at strabismus surgery or ptosis surgery as the two options we have. However, because myasthenia gravis results in variability of the ptosis and variability of the strabismus, it's generally contraindicated to be performing surgery, either ptosis or strabismus surgery, on patients with myasthenia. In this particular condition, you need to be fairly confident that for strabismus surgery, the patient has a deviation that is stable. In this instance, you would then perform the appropriate surgery as per the surgeon's preference. With regards to ptosis surgery, again, you have to be confident that the ptosis is relatively stable, it's persistent, and then one can consider blepharoptosis surgery in this particular instance. Okay, so overall, a patient who's been diagnosed with myasthenia gravis needs to be managed by a multidisciplinary team. And this team will include a neurologist and an eye care team that most often includes an orthoptist and an ophthalmologist. In relation to the management options, some of the common approaches are prescribing of drugs such as anticholinesterase or steroids. And for some patients, it may be recommended that they have a thymectomy. In relation to the ocular signs and symptoms, ptosis crutches could be prescribed to patients, obviously with the ptosis. Prisms and occlusion can be prescribed to those complaining of diplopia, but again, prisms are very difficult to prescribe in these patients. And Botox can be given where there is stability and we want to see if we can alleviate diplopia, or have a look at what the post-operative outcomes are likely to be if the patient were to be operated on. In relation to surgery, strabismus surgery and ptosis surgery are an option, but as mentioned earlier, these should not be performed unless the strabismus or the ptosis is persistent and relatively stable. Otherwise, you should really not be performing surgery on these patients. Okay, that brings us to the conclusion of this video. Thank you for watching.